Hello and welcome to the topic Hepatocellular and Biliary Duct Tumours in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define hepatocellular and biliary duct tumours, discuss the pathophysiology of hepatocellular and biliary duct tumours, explain the clinical presentation of these two tumours, outline the investigations in the diagnosis, and finally discuss the principles of management of hepatocellular and biliary duct tumours. Let's get started. Hepatocellular carcinoma is a primary malignancy of the liver that occurs predominantly in patients with underlying chronic liver disease and cirrhosis. It is the most common type of primary liver cancer. It happens often in people with hepatitis B or hepatitis C infection which has caused cirrhosis. As for biliary duct tumours, this is a type of cancer that forms in the bile ducts, also known as cholangiocarcinoma. The biliary tract refers to the liver, gallbladder, and bile ducts and how they work together to make, store, and secrete bile. Hepatocellular carcinoma or HCC primarily arises in a cirrhotic liver where repeated inflammation and fibrogenesis predispose the liver to dysplasia and malignant transformation. Viral infections with hepatitis B virus and hepatitis C virus lead to enhanced hepatocyte turnover as the liver attempts to replace infected cells that have been immunologically attacked. There is some evidence to suggest that HCC develops from hepatic stem cells that proliferate in response to chronic regeneration caused by viral injury. The cells in small dysplastic nodules appear to carry markers consistent with stem cells. Hepatitis B virus infection can also cause HCC in the absence of cirrhosis. Hep B virus integrates its deoxyribonucleic acid into the host genome, leading to genomic instability and chromosomal rearrangements. Hep C uses ribonucleic acid to store the genetic information and therefore does not integrate into the host genome. Hep C-related hepatocellular carcinoma is found almost exclusively in patients with cirrhosis. As most liver cancers are observed in association with cirrhosis, it is important to consider the severity of liver disease when selecting a treatment strategy. And that's why here we would use Child-Pugh scoring, which determines the severity of the liver disease on the basis of serum albumin, bilirubin, prothrombin, ascites, and encephalopathy. Bile duct tumours cause bile duct obstruction with biliary stasis and consequent alteration of liver function test results. Prolonged biliary obstruction causes hepatocellular dysfunction, progressive malnutrition, coagulopathy, pruritus, renal dysfunction, and cholangitis. The risk factors for bile duct cancer include family history of congenital fibrosis or cyst, parasitic infections, gallstone and hepatolisthesis, primary sclerosing cholangitis, ulcerative colitis with or without primary sclerosing cholangitis, and also drugs. Patients with bile duct cancer may have a family history of congenital hepatic fibrosis or cystic dilatation, which we call Caroli disease. Symptoms of hepatocellular carcinoma include pain in the upper right part of the abdomen, a lump or feeling of heaviness in the abdomen, bloating or abdominal distension, loss of appetite and early satiety, weight loss, some general signs or symptoms such as weakness, nausea and vomiting, jaundice, having fever, or pale chalky bowel movements with dark urine which indicate cholestatic jaundice. As for biliary duct tumour, it might be very vague, the symptoms, hence you may want to look out for abdominal pain, weight loss, and generalized itching. When we are looking for signs of hepatocellular tumour, always look out for signs of chronic liver disease, as most hepatocellular carcinoma mentioned is a sequelae of chronic liver disease or liver cirrhosis. So look out for pruritus, jaundice, splenomegaly, evidence of variceal bleeding, cachexia, abdominal distension, and hepatic encephalopathy. As for biliary duct tumors, you may want to look out for jaundice as well as fever. When it comes to lab tests, among the investigations that can be carried out include blood tests as well as other body fluid tests such as stool tests. For blood tests, both cancers, it's essential to run a full blood count, electrolyte levels, liver function tests, coagulation studies, alpha-fetoprotein, levels of serum carcinoembryonic antigen, some autoantibodies as well, looking out for the potential cause, such as serum mitochondrial antibody tests, as well as serum markers of the synthetic function of the liver. Imaging studies that can be useful include ultrasonography, CT scans and MRIs, which are generally non-invasive imaging studies, and invasive techniques include CT during hepatic arteriography, CT arterial portography, conventional hepatic angiography, and digital subtraction angiography or DSA scan. This will help look for the vascularity of the tumor that's involved. For biliary duct tumor, one may do an ultrasound, a CT scan or MRI to have a closer look of the tumor. Apart from that, a magnetic resonance cholangiopancreatography or MRCP is something that is used for specifically looking at the biliary tract. Non-operative therapy is administered for patients who are not candidates for liver transplant or resection. Tumor ablation can be offered to extend life and potentially to downstage the tumor so as to permit transplantation or resection. Alternatively, patients who have advanced disease may benefit from palliative care interventions rather than subjected often to ineffective therapies. Brachytherapy, which is another form of treatment option, involves the local delivery of low-dose brachytherapy to the tumor. One such treatment uses 20 to 40 micrometers glass beads that are loaded with radioactive therium and delivered angiographically. The radiotherapy is then delivered over a span of 10 to 12 days. Next would be chemotherapy. Systemic chemotherapy remains the mainstay of therapy for patients with advanced hepatocellular carcinoma who are not candidates for surgical resection, liver transplantation, or localized tumor ablation. Unfortunately, HCC is minimally responsive to systemic chemotherapy. Resistance to chemotherapy may be caused by universal expression of the multi-drug resistant gene protein on the surface of the malignant cells, leading to active efflux of chemotherapeutic agents. Sorafenib is an oral agent that has anti-angiogenic, pro-apoptotic, and RAF kinase inhibitory properties. It was approved by the US FDA for use in patients with unresectable hepatocellular carcinoma. You may also consider other non-surgical measures. For most patients, treatment options other than palliative care are limited. For patients with Child-Pugh class C, cirrhosis, and contraindications for transplantation, any intervention has the potential to result in progressive hepatic decompensation. In these patients, treatment focuses on pain control, ascites, edema, photosystemic encephalopathy management. For biliary duct tumors, one may consider resecting the bile duct cancer. This kind of cancers are usually in the area such as the lower part of the common bile duct or perihilar area where it can be removed completely by surgery. For unresectable metastatic or recurrent bile duct cancers, which cannot be removed completely by surgery, most patients with this kind of cancer cannot have it removed. And another consideration is that metastasis has occurred where it has spread the cancer away from the primary site. And when this happens, the cancer may come back in the biliary ducts, liver, or gallbladder. Less often, it may come back in distant parts of the body. So here, chemotherapy can be used in order to shrink the tumor size. However, eventually the resort would be for palliative care. Radiation therapy is a cancer treatment that uses high-energy X-rays or other types of radiation to kill cancer cells or to keep them from growing. So there are two types of radiation therapy that are used. The external radiation therapy, which uses a machine outside the body to send radiation towards the cancer, and internal radiation therapy, which uses radioactive substances sealed in needles, seeds, wires, or catheters and are placed directly into or near the cancer cell. So both external and internal radiation therapy are used to treat bile duct cancer. Another form of therapy is known as hyperthermia therapy. This is a treatment in which the body tissue is exposed to high temperatures to make cancer cells more sensitive to the effects of radiation therapy and certain anti-cancer drugs. Last but not least, we have got radiosensitizers, which are drugs that make cancer cells more sensitive to radiation therapy. So combining radiation therapy with radiosensitizers may kill more cancer cells. In terms of surgical therapy, in view of the absence of effective chemotherapy and the insensitivity of HCC to radiotherapy, complete tumor extirpation represents the only opportunity for a long-term care. As for surgical therapy, in view of the absence of effective chemotherapy and the insensitivity of HCC to radiotherapy, complete tumor extirpation represents the only opportunity for a long-term cure. In patients with decompensated liver disease, liver transplantation offers the potential for a long-term cure in patients with limited tumor burden. Alternative treatment include local ablative therapy or TACE, and transarterial brachytherapy can be considered in patients who are not candidates for curative procedures. So in summary, we have looked at hepatocellular and biliary duct tumors, which are tumors involving the primary tumor that involves the liver as well as the biliary duct. We have looked at the pathophysiology and potential risk factors for these kind of tumors. We have also gone through the clinical manifestations of both hepatocellular carcinoma as well as biliary duct tumors, which can be categorized into general signs and symptoms as well as ones that are specific to the area that's involved. Investigations which are useful in terms of identifying the cause of the presentation as well as complications of the tumor and monitoring the progress of response. And finally, the different type of approaches we have for the management of hepatocellular carcinoma and biliary duct tumors when it comes to the different stages of the tumor. We have come to the end of this topic. Thank you.